we'll go ahead and get started with our afternoon. I know we have just 1 hour, so I'd like to call up the 3 panelists this afternoon. We're going to be doing a panel session, and so we have Commander Kevin Gaines. Commander Kevin Gaines attended Oklahoma State University, where he received an undergraduate degree in chemical engineering. He then attended medical school in Arkansas and completed medicine residency in Oklahoma. Dr. Gaines started his career at Gallup Indian Medical Center in 2002. He now serves as the Chief Medical Officer for the Navajo Area Indian Health Services and the Acting Director of the Office of Environmental Health and Engineering. Welcome, Dr. Gaines. Our next panelist is Dr. Michelle Branzer. Dr. Michelle Branzer is the Health Service Administrator for the Navajo Nation Division of Behavioral and Mental Health Services. And then we have a third panelist, and that's Mrs. Cindy Lincoln. She is the social worker, and she works at the Sage Memorial Hospital, Department of Behavioral Health. So welcome to the 3 panelists. And then I guess, and of course, welcome to each and every one of you. So welcome to the Tribal Healthcare Panel. Today, we are convening leadership within federal, tribal, and 638 on sharing knowledge and explore opportunities to cultivate healthy communities and promote accessibility to quality health care. Overdose remains the leading cause of injury-related deaths in the U.S., and most involve opioids. Given the current crisis, we want to learn more about what's working to prevent addiction and reduce overdose deaths. I'm happy to start today's panel with leaders who are working to shape policy at the tribal and federal levels. So I would like to give the floor to the panelists. Please introduce yourself and give a brief overview of your organization before we start the questions. Thank you.
All right, thank you everybody for coming today. As mentioned, I'm Dr. Kevin Gaines. I'm the Chief Medical Officer for Navajo Area Indian Health Service. We oversee 5 service units that include 14 different facilities across the Navajo Nation, and those 5 service units are Gallup, Crown Point, Shiprock, Chinle, and Kayenta. And they have satellite clinics in their communities as well that serve our patients in some of the more rural locations. And so that's a little bit about me and our facilities.
Well, good afternoon, everyone. I'm Michelle, Dr. Branzer. As stated, I'm the Health Services Administrator. So, Nanisht Eja Nishlan, Tolbajni Aji Bashashin, Kia Ane Dashachain, Todatini Dashanale. And I come from Pinedale, so the eastern side of Navajo Nation. As the HSA for the Division of Behavioral Mental Health Services, we're underneath the Navajo Department of Health. And so our focus is really on the substance use component of treatment, prevention, outreach, but we also do co-occurring services like myself and others. We have our licenses as mental health as well as substance use disorder. So we really work within what we call the American Society of Addiction Medicine treatment services, and that really requires a continuum of care, which Dr. Christensen mentioned a little bit earlier when I was here earlier this morning. So that is DBMHS, and I just wanted to let you know that we have 11 outpatient treatment centers across Navajo Nation. We have 1 residential. It is focused on the youth, so it's the Youth Residential Treatment Center in Shiprock. And then we opened up our first sober living center, which is in lieu of what you may have heard with Operation Rainbow Bridge, the access bad actors or fraudulent facilities that once weren't providing good care to our Diné, and also we're recruiting our relatives down to go to these not so good treatment facilities or sober living. And so with that, we did open our first sober living for adult men and women and their children. So it has been a learning curve for us, but those are currently the treatment services and the sober living that we provide. Thank you.
Yade, Shay Wanagan in Shlam, my Dishkishni Bashashin, Toricini Dashachado, Kia Ani, Dashanala, Cindy Lincoln, Aya, and Shia. I am one of the social workers, counselors at Sage Memorial Hospital. Currently, as some of you probably know, that we have a new hospital, and we're excited to about that. As far as with behavioral health, we have peer support group. We also have the COPE that we work closely with. We work with not just people from Ganado, but also the surrounding area, Steamboat, Kintlachi, Clagato, Greasewood, and those areas. But we also get a lot of patients out of our service area from Chinling, 40 Fines area, even from the Gallup area too. So we're excited. We currently, there is 4 counselors, and all of our counselors except one were Navajos, and we have stopped using contract providers, so we are permanent staff. And I believe this is the first time that Sage Memorial Hospital has done that. We've always used contract health, so now we're able to build good rapport with our clients, where a lot of trust can be built instead of having contractors come in and out all the time. And because a lot of people will kind of be hesitant to come back, so we're proud of that. And 2 of us Navajos, we speak the Diné language, so we're able to give counseling in our own Diné language.
Thank you. Thank you for those, for the introductions, and thank you very much for allowing you to listen to the questions. I have several questions. So the first question I would like to ask is, can you speak to the importance of early intervention on opioid and other substance use disorders?
So certainly, as far as this goes, an ounce of prevention is certainly worth far more than a pound of cure. Once folks get into substance use and addiction, it's very difficult to treat, and for them to turn life around and get back on the right track. So anything we can do to either prevent or make an early intervention is certainly beneficial to our patients. But as with any substance use issues, it doesn't just affect the patient, it affects the entire family and support system of that individual. And so the more of those folks we can draw in to help as well, the better.
And for myself and DBMHS, we have a very active outreach staff group that really go out into the communities. And I think for me, that's the earliest of intervention is in our communities, especially for opioids, because again, it's a difficult, in the communication of, even treatment for opioids. Currently, it's more harm reduction, meaning that what has been helpful to help those that become addicted to opioids is medication treatment, assisted treatment. And what we found with our outreach and with the Center of Harmony and Recovery staff going out and doing that education, letting the community know this is in our backyards, it's not hidden, it's around. And because the treatment can follow those things, that the earlier intervention is just so that people know there's help. I think that's the biggest piece, because sometimes with those substance use challenges in our families, many people, we don't want to talk about it, or if it gets talked about, it's in a negative manner or something like that. So that's what I would say is really getting into the community, working with the outreach staff that is available probably amongst different agencies and entities, because the treatment of it is, as was mentioned, a challenge. Substance use disorder is a challenge. And so what we found, going back to some of the feedback from our staff that go in and talk to the community, is like, well, why are you giving a medication to stop somebody? You know what I mean? From helping them to not go and do the opioids, you know what I mean? So it really is becoming a little bit complex. But I think overall, the more we're speaking about it at all different levels in our communities, it's been helpful. And I think that is something that we can probably continue to have to work on, especially as, DBMHS isn't necessarily the medication-assisted treatment providers that's coming from the other healthcare organizations. So really, again, that early intervention is just getting that information to me, whatever age that may be, our elders, our little ones, the school age, the professionals, whoever it is. So that's what I would say. Yeah.
I believe education is really important. The sooner, we educate, especially, students in the school, if we can get to them and let them know the dangers of starting to use these substances. Also getting family involved, I think, is also really important. The more the family is educated about substance use, the more they're able to help their loved ones as far as bringing them into treatment. And currently we have our COPE and our peer support that are out there doing education in the community, like in chapter houses, and they're bringing families together, and our behavioral health is doing arts and craft with them to develop that that education, and just to help their loved ones with their struggles and learn more about the substance.
Thank you for those answers. Ado shin kuje adanek echigo shin kadan kodo trago yiltahanal U.S. government ado Navajo Nation ado 638 ako what hada hasti a early intervention with yahibe na ide kito hashit ado les ado ade hada hasti ge ya kujin antkin kumbana bane kregit al na halona antkin education and awareness ado hashin sago e ya kwa nihig eda heda hashin sago ye etchit na wil now ato ye go etibidinil soda shehet abakai do walche aje ya e kum biltahte nahi resources deithne ado hashin sogo e ya ahawan has ade ishin the bagan shin big ishin jo e do bilbada hazon e bilo al hashin sogo ye el kaido jahno kodo hada hasti. So thank you very much. I was just translating in very shortly how the question and how you all responded. So the next question is, what are your thoughts on the stigmatizing of people suffering from opioid use disorder? How is your organization preventing stigma? So there's two questions to this one. So what are your thoughts on the stigmatizing of people suffering from opioid use disorder? How is your organization preventing stigma?
All right, so certainly it's an issue. I think if we reflect back historically, things have improved some, but there's still a long ways to go with this issue. I think one of the ways we try to address it and prevent it and make improvements in the healthcare system is we treat substance use disorder much like we do any other diagnosis. We'll screen for it, assess the patient for their willingness for intervention and treatment, and if they're willing and open to treatment, then offer that treatment and referral out if necessary. There's also the public health component of getting education out in, as was mentioned, with the schools and families, and getting more community action and awareness in the population and the community as well.
All right. So for, I guess the perspective I can bring to this is, the stigma is very real. I think the first question of my thoughts on the stigmatizing of people suffering, and I do really think that's a huge reality, because like I said, on Navajo and even off Navajo Nation, the stigma is something that our people that are wanting help encounter, right away, I would say, even when they start using. Like I said, the addiction doesn't seem to favor anyone in particular, usually. It can happen to anyone, any age. And so I really think the best way to help that is, to be kind. I don't know if that's simple, but it really is when you're speaking to somebody suffering or in pain or, coming up to you on the street, you know what I mean, at the grocery store, looking for things and you're not sure, because all these things lead to our own, what I guess we sometimes call implicit biases, which leads to stigma. And even I know we can have it as providers. And so really learning to be aware that sometimes that may be our response, maybe not what we want, but it may be there. And even sometimes the way we speak about people that come into the facility, because we're a gamut of continuum of care here. So I always think about, well, it took that person a lot of courage, or their family member a lot of courage, to bring them to our office, no matter what. If they're under the influence, if they're feeling shame, if they have to bring their children, whatever it is. So our job, and I think in the way preventing stigma and how I, hopefully I'm role modeling for that for staff, and as we do other trainings, things like that, is, again, just to go back to that, to be kind. But I know sometimes it can get a little bit more complex as well. So just keeping it simple, I think that would be the best way, especially as providers, because as I have stated, just seeing either in the substance use realm or the mental health realm, when somebody reaches out for help, they themselves, reaching out for help, that's a really quick, needed response to be not, feeling like, well, this is the third time they're coming into our office, or anything that would be implicit, like in a negative, biased manner. So that's how I say you would help in reducing any stigma. Thank you.
I believe stigma is, a lot of it is based on historical trauma. There's a lot of stereotyping, among our people from as far as back as we can remember. So a way to prevent something like this is personally, a patient or a client might come in and say, I need help, I'm an alcoholic. So we got to change that mindset of, let's say you struggle with alcohol. Then that way it gives the client the hope that these behaviors can be changed. If we go on believing, saying, yes, you're an alcoholic, then there's, I don't see any hope in there. So a lot of education that has to go with not just the client, but also as far as the family too. They need to be educated. It's okay. It's okay to talk about alcoholics. It's okay to talk about substance. It's okay to reach out for help. Because I think going back to historical trauma, that has been something that has, enclosed us not to talk about these type of things. And education, I think, is something that can prevent that. Thank you.
Thank you again to the panelists for answering those questions. As they ni ado alla gel del beige kun hidna ye itchen da huilt eto hashin sogo eya ik e kandag he ado hashin sogo eya kunde oyo do betrahodat edo da hashin sogo abiye oyu da ilaha del Lata eshe hit abans da ke stigma will yahegi adenek echigo a stigma hit ajani. Anybody know? I see some practitioners in here in the session. So the question was, how is your organization preventing stigma? Adoshi eshe ba ya atkio ya lata e ala do ba ya del tkit ande one has undid the ala big sitna atahagi. Ero da hashin sogo as they need mental illness when say case ba or yobache na hot e or that or yoba ya del tkit o kuden danil in do e ishin or ya stigma o kunna o kun betin da huiljo ado shi hot e la ya na lo ban today case ako kuja ye hadasti ge ya ba ya del tio education and awareness and hot all atlahandat le ho kun ya dal tio hot a she yan jono e a wante kachi huan da do kato huan da ba ya dal tio le tid big da do thanit a do ben hit hasna git a hot a ya okay, we're going to move on to the third question. On the Navajo Nation, resources for opioid use disorder are limited. Can you share the referral process for your organization? Are there specific pathways established for immediate referrals to behavioral health facilities?
All right, so from the federal standpoint, we do have a referral system, purchase referred care, formerly known as contract care, that many of you may be aware of. So we can refer patients out if we don't have the services available at the facility to provide that care. And that's true both for whether it's inpatient or outpatient therapy. But we also have some internal programs available, especially at our larger facilities with more staff and better teams. They are able to, for instance, one of them is called the Bridge program. So if a patient comes into the emergency department suffering from substance use disorder, they can actually begin treatment in the emergency room at that visit, be referred to a team in the ambulatory clinic where they're seen within a matter of a few days to be able to continue and continue on in that care and that treatment. So there's both some internal referrals that can be done as well as external. But I also don't want to make it sound like there's plenty of resources for everybody when it comes to behavioral and mental health services across the United States. Whether it's IHS, Indian Country, Navajo Nation, there's really not enough resources to meet the needs. We do the best we can with what we have. We focus on those with the most urgent and significant needs and go from there. But we do have processes both internally as well as externally to get patients out. I know in our border towns there's community rehab programs and stuff that we can refer our patients to. There is now the Sober Living program that we can refer to. Again, limited scope. Hopefully that will grow and become larger because the need is certainly there. But we do what we can with the resources we have, and certainly if we're able to find resources outside our programs, we will refer patients when necessary.
For myself and DBMHS, similar to Indian Health Services and probably other healthcare organizations, we have our referral process that starts right away at intake and screening, especially if you're coming in wanting help or treatment. And so that way you can identify right off the bat, hopefully, or with drug screening, to be able to know what is the real issue. Because I think that's sometimes where, like you said, we have resources, but they're sometimes more spread out or even on the border towns off nation. And so it really takes that communication, especially for families, because their loved ones are the ones that they're very concerned about. And many times it's just helping them walk through that process as well. Case in point, a family member calling, this is an example, me asking they wanted detox. And so it was like, well, so where's your person that's located? And this is on our agency, DBMHS, to always improve, is because the staff, whoever answered the phone, really didn't have the resources to walk that family through. And so they ended up coming to me, which is fine. So I walk them through. So I think the goal is for these referrals, it sometimes is that person-to-person handoff type of referral, as opposed to you came from ER, somehow you ended at DBMHS for some kind of treatment, it takes screening, and then maybe we had to send you to somewhere else, Asia or 638. So that is its own process, and I think that's where I think all of us as continuum of care can always improve, because that's, I think, sometimes that from the ER to DBMHS to another program where we can really have difficulty or people following through on those referrals, and ultimately we know they want it or they seem to be requesting for help at that time. So I think overall that's what I would say about just establishing those pathways, because again, our organizations or our staff need to know those processes as well. So if that person, family member, mother didn't get a hold of me, I really get concerned, well, what would have happened in that situation for the detox that was needed for their adult child, though? You know what I mean? So really those are the realities is, we have to always help not just the people that are requesting help to follow through with referrals that are given, but also on our time, our processes, so it's a more person-centered kind of referral process, I would say. So thank you.
With Sage Memorial Hospital, we treatment usually, again, going off of, it starts with the ER, in the ER, and it's usually based on our intake. We'll decide at the time what will work best for our client, and we've been working closely with the REBA department, and also all of our staff were pretty new. We are excited to branch out, and we've been inviting other entities to have lunch with us at Sage Hospital to build that I guess, a kinship with them to help, in that way as to what we can do with some of our clients where we may send them, and just kind of collaborate with them to give them the best care that we can. Right now, I believe we have talked with the 45 IHS, with the Chinle IHS, and we're looking into other resources so we can build that up for our clients. Thank you.
Thank you for answering those questions. Adoshin kujinaide kide het au ayan hidden kunde a opioid will get higage and the hoit a hosh het au a referral process. Not so suddenly, Stashi Arjanadi Dal Ando Kujida Hajila Yat Eho any kite or what Yat Eho Ajasi Hasin has all without Nakite all watching in Niger Aya Hadas Zido, a Chia del Tiodo referral process not so suddenly on the Chita wheel now, though hitting the wheel now, she with on hidden Nabakai di Jatrodane. Okay, question number 4 is following up on the previous question. Addressing substance use disorder on the Navajo Nation involves collaboration. Can you share current partnerships you have with partners between tribal, federal, state, and 638 organizations?
So certainly, given the need for further resources, this is an important issue for us to be able to collaborate with other resources in the communities and region. Again, everybody's under-resourced, so nobody has a whole lot to be able to give elsewhere because they're struggling to keep their own programs up and going. And again, this isn't just to the Navajo area or IHS. It's a nationwide struggle right now with substances and treatment for those. We certainly work with Navajo Nation Department of Health a fair amount, and trying to there's some collaboration certainly that goes on there, but trying not to create redundant programs and doing parallel work, but making sure what we do augments one another to be able to provide the best services to the communities and the people we're here to serve. And a lot of the other collaboration, again, goes out to the regional and community resources around the reservation for those who need inpatient, and so we're living access and being able to refer patients there when they're willing and able and prepared to do that, so that we're able to get them those services as well.
Okay, so for, like we said, the collaboration, or Dr. Gaines said, for the collaboration with IHS, many times, it's just a process, I think, for memorandums of agreements or understandings to really help those expansion, if you will, of collaborations, because I think when you work in any government system, that's kind of what ends up happening. But overall, I would say for the nonprofits that DBMHS has really worked with, one of them have a booth out there, Day at a Time. and they are more in the, grassroots, if you will, self-help, peer support. We're really trying to tie in what DBMHS, we don't necessarily have a peer support program right now, but we're working to create that with our Department of Personnel Management and other government structures that's needed to do that. And then others, such as the border towns, because until we are establishing the inpatient or residential treatment centers on Navajo, or the full detox center on Navajo, or crisis center on Navajo, we do have to work with the outside entities a lot of times. I know REBA, that's Navajo Regional Behavioral Health Authority. So DBMHS, we have this program with Arizona Medicaid or Access, and it's an intergovernmental agreement where we have case managers and case assistants that help with the placement of the person who needs help in substance use or mental health. And so that is a good partnership, but it's been a rebuilding one, if you will, like I mentioned, with the unfortunate things that were happening down in the valley with unlicensed or just, people that are looking to make money, honestly, and not really about the help. So it really has a lot of ripple effects. So I think it is up to date, just making sure that, we build wisely, because the referrals, I don't always see them needing an MOU. I hope to, talk to ER doctors, whatever that may be, and create those referral, or just the partnerships more, and then work up till these big agreements that need to get done, because sometimes that's where it has to go still. And then I would say in the last one, and that one is just the procedures piece. I think COVID really helped in that way, if you will. Like, we really had to work with IHS procedures, other healthcare procedures, and that was really on our end so that we could take care of the needs, and even off-nation, the needs of our people. So I would say that is really where I would say a striving to, where we currently are with partnerships for Navajo Division of Behavioral and Mental Services, or Navajo Department of Health, and then also outreaching further to expand our programs. Thank you.
Currently, Sage Memorial Hospital, again, we're all new staff, so we're kind of reorganizing our behavioral health department. And right now, we have our peer support group and also our COPE that has been tremendous help to us as far as education and getting resources and so forth to our community members. We are also, again, working with the REBA to get our clients, if they need to be inpatient and treatment, off the reservation. And we are currently developing a OPI team, IOP, and so that's going to consist of 3 hours of training every week for 12 weeks, and that is currently in the works. So hopefully, I believe in October, we'll be starting that. And right now, I would say Community Bridges is one of our resources off the reservation, with getting our clients to detox if they're unable to do it in our hospital. And so again, we are developing other entities to work with us, and so that's what we're working on, and hopefully by next year our program will be pretty solid as to work with other resources. Thank you.
Thank you to those responses. The opioid agent, the whole hit all call not jaho a kun the Bakite or with partnership with Ninigi between tribal, federal, and 638 organizations. Equi Yahadas Zido, a Jiatel Teodo Nalsos, a Jedal on the referral process or Yagi, Ando Hashin Sogo Eya, Quaed do a resource at Dena Dobaka, Aliedo J. Contract health do referral process yahadasi, and then just for all of you to just go through the booths here today and actually pick up some information on some of the resources that may be available that we may be missing. So, ando hashin sogo eya hey the hut au baka jili do she ya na ijdil kido to resource itla you nas ishe hate au baka it au what dane. Okay, the next question is typically opioid use disorder is also associated to polysubstance use disorder. What action is your organization doing to provide services for overall health and recovery? How is this supported with culturally relevant medicine?
So yeah, I'll confirm that many times it's not limited to opioid use. It's polysubstance abuse that we see, or polysubstance use that we see among individuals who are using opioids, and often mixed in with some other mental and behavioral health issues. So you've really got to approach the patient from a holistic standpoint to be able to address that adequately and provide them the support they need to be able to make progress. And part of that is traditional healing, and most of our service units do have a traditional healing program in them that patients can be referred to if they're open to that and want to seek that out. And again, we can also sometimes refer individuals out to Native practitioners as well through some of our programs, so we do have ways of incorporating that in. Many of our behavioral health practitioners are Navajo and speak the language, and so they can certainly incorporate more of that in when the patient's fortunate enough to get one of those providers as well.
Yes, I have just, did a lot of that. For DBMHS, we do have our traditional practitioners that work at the different treatment center sites, and if there's not one available at one of the treatment center sites or sober living, just our internal referrals can be made so that is quickly addressed as quick as we can. I think the challenge sometimes is, screening appropriately even in the beginning, like in a sense of like the healing component of their spiritual sense of the person, because as we all think of recovery, at least I do, in wellness, it is a spiritual journey many times. Things that people grew up with or did for some reason, the ones that stand out to me are when there was the men's unit at Norbeck's facility when I first was hired. Many of the men, were very traditional or came from those backgrounds. But because of their substance use, they really had disengaged for a long time, many of them. And that was their go-to in treatment, to be able to do and work with the practitioners, with the teachings, with the language, with herbs, doing ceremony. I mean, it really was a re-engaging process for many of the clients then. And then speaking for our youth that we have in the youth residential, both it could be male and female or boys or girl, is the same. Many times they want to know that, but maybe they didn't really grow up with some of those teachings. So really it shows that healing process of the polysubstance use as well, because if you think about our youth, the ones that are needing that kind of help in an inpatient or residential treatment is they're not getting the support they need from their family, or there's own family issues going on. They're not engaged in the school education environment. Their behaviors are not very good. And I was talking to staff earlier this week, even the clientele, the youth we're seeing are somewhat more hostile, more aggressive, carry weapons, things like this that are opioids, things like that we, even as an organization, DBMHS, when we think about the polysubstance use, we need to be aware of and really help with our staff to know how to help those individuals. But many times what I've noticed being back home, it is the spiritual component with the traditional or faith-based. We've had a really wonderful faith-based counselor as a pastor that worked with DBMHS at the time, or DBHS. And it was amazing to see, again, the grown men, this is on the men's unit, singing hymns, on Sundays. You know what I mean? This is more residential again. And connecting in another spiritual sense. So it really, I think, is very important that, you know, we offer that kind of holistic, because polysubstance is just, I think, layering and layering or jumping around to different things to kind of help relieve that pattern of, or their use history. So that's what I would, my input would be. Thank you.
I think going back to the cultural teaching of things, a lot of our young people are struggling with substance. They might not know that they have the traditional gift of, on the, you know, culture, the native way, with the Navajo way of teaching. Maybe they have a hand trembling gift, but they don't realize what it's for and how to use it. And a lot of our youth has turned to alcohol. So Sage Memorial Hospital has recently hired a traditional practitioner to kind of fill that gap, to work with our youth, to let them know that it's a gift, it's nothing to be scared of. How do you use it? So I think it's really important, going back to our traditional teaching. And I, for one, I speak Navajo. I use a lot of historical trauma in my counseling. We work on geogram with our clients to kind of like let them realize what the family dynamic, the you know, like the trauma, how they can connect their own dots to see where they can break their own cycle in their family. And I think it's something that a lot of us, we don't talk about. So I think historical trauma is something that has to be talked about. It has to be discussed for our people to understand why maybe Grandpa Che Nali acted in this way, why they turned to alcohol. The boarding school system is a big issue too. Mom, dad, grandma, maybe they were abused in there. So why do they have these anger issues? So if you let your clients kind of connect their own dots and realize, oh, okay, I understand. It wasn't because they didn't love me. This is all they knew. They get a better understanding of why they struggle with substance themselves. So traditional counseling is really important. We are currently in the works of doing sweat lodges for our clients, and also our traditional practitioner has prayer service, cedering, those type of things are being offered to our clients right now. And that has never been done at Sage Hospital, so we're really proud of that. Thank you.
Chokodo naide kidi heshit au eya akujen kidne ba ol ilchido nahagaja da eshit au eya bildal nishot no e ada ye hata hasti a traditional practitioners ol gahigi she e aje eya bilda anishto shin sogo e dest e elo da de ji so des enjoy a he des on hot au de kun hidne la ye Anda Kaigido, Tinda Bilahagijoy, Aje, with Albakaito, Wotane. Okay, down to the last question because of time. Substance use exposure often begins in youth and adolescence. With adverse childhood experiences on the Navajo Nation, how is your organization targeting prevention in the tribal communities?
All right, so I certainly agree. The age at which children are being exposed to some of these issues seems to be getting younger and younger. And the key to making preventive interventions is both in the school and in the families and in the homes where they live. So as a federal facility, we have our public health divisions that certainly get out and do some teaching and interventions in the schools and homes and communities, provide education, work with the CHRs in many cases to be able to do that, and just trying to provide information both for prevention as well as hopefully early intervention if folks do find themselves getting into trouble, and letting them know there is help available and to seek that out when necessary too.
So for me, as Nika said, talking about the youth that we work within all of our communities is really, I guess, trying to bridge any gaps, if you will. I was thinking about it, like even many of us have our own children or grandchildren, and really are trying to understand what they're going through. Sometimes that's the hardest part. Like I remember talking to some of my, children or nephews and nieces, and they know what I do, and just seeing, okay, what healthy outlets do you have? I was just asking those questions, and sometimes, and even more at the high risk, it's really difficult for them to pinpoint. Besides their electronic devices, this is nowadays, of course. So for me, of course, prevention, getting, as we all know with our traditional teachings, the youth to, see where they come from, at least for sure the Diné youth or any indigenous teachings that are there, that I think helps engage the youth. But there's an interesting conversation, too, that I've had with some staff sometimes at the other more youth programs like Diné Youth Center, things like that, and seeing how we can partner, because sometimes, they should be focused on school, or if they're at risk, maybe they're not in school. So how do we really outreach to those youth that are somewhat already in the process of disengaging? And so those are the conversations. It seems like sometimes we just have to throw out our ideas to say, will this help? I know sports, basketball is always a big thing for our youth. Running sometimes is very big now. Cross-country season is here for the schools. So I think that's the piece I would say for the youth and even tying it in with our prevention outreach section, is seeing what activities that their communities where the staff are in those treatment centers, what they're thinking is going to be helpful to engage youth. Because not all the youth are using either. If they're not, they witness it, and then they may feel a little bit helpless themselves at times. So it's really the whole gamut, I think, and really learning in ourselves, in the communities we come from, and the programs that we really can provide those other outlets of healthy activities or things like that. So thank you.
I think due to a lot of stigmatization at home, a lot of times students don't really hear about substance until they get into the school system. So we've been currently going out to the school. We visit Kintlachie School to see if we can come in there and teach the children about the dangers of substance abuse. We also work closely again with COPE and our peer support. They do a lot of outreach into the community, chapter house level. They do activities. Just recently they did art activities with the young kids, and they were really involved. I noticed they like a lot of arts and crafts, so they implement a lot of the substance use danger teaching into that. And as far as the school, we have a lot of work still to do, but again, our program is pretty new, so we are planning to reach out to not just the elementary level, but into the high school all the way up to see what kind of resources they will allow us to bring into the school to educate our youth. Thank you.
We appreciate those responses, so we'll go ahead and open it up for questions. Does anybody have any questions for our panelists up here from Indian Health Services, from Department of Health, DBMHS, and then from the 638 program, Sage Memorial Hospital? Anybody? Hi,
this is a question for Dr. Branser. I think I heard you say at the sober living facility in Chinle that families can be there, like parents can be there with their kids. This is more of a comment, but I just wanted to say that I think that's really amazing. I'm a doctor at Gallup Indian Medical Center and work with a lot of patients struggling with substance use disorders. And I think a huge barrier for parents, especially moms, is that they really want to get the help they need to be there for their kids, but they can't because they're the only person caring for those kids. And so it's a really impossible situation where they can't engage with care because they can't leave their children. And so I think that's really wonderful that, families can be together in those facilities. Also just breaking the cycle of, kids growing up in families really affected by substance use disorders, and then that leads them to go down the path of having a substance use disorder. If we can actually help those families, help them stay together, that's really amazing.
Thanks for your comment. I do agree it's something that's always needed here on Navajo or everywhere in general, but what's good about, I guess, being in a sovereign nation is, we still follow Arizona State, New Mexico State, Utah, all of the regulations, if you will, but we're very mindful of the extra component of bringing in children to the facility so that everybody is safe. Because what we found with bringing in children is, many, like you said, of the residents, we call them, in sober living, coming in that have had treatment maybe multiple times, things like that, is they're still learning to be the parent. And we have to help them with resources to do that in a good way. Because already their children, even though they may be with them now, there's a big healing gap that still needs to be addressed, especially as they get to be teenagers. It's what we've seen so far. And helping the parent then to really engage as the parent, the child to be able to, or the youth to be able to work with their parent in a different way. So yeah, it's been great to see. November will be our first year of having it, so we'll be evaluating it. I do hope to do more of sober living across the Navajo. We do have the facility I mentioned in Shiprock that would be another place to have sober living or sober housing. So that's, again, just looking at the staffing we have that we can do that. And again, sometimes it's just training even us as a provider. It's not necessarily treatment. We're not offering all this. It's peer support, it's cultural, it's spiritual, it's resource-based, and how do we help that way? So I do agree. It was needed, and it's good to see, as we have seen, probably I would say 80% of those that we have served thus far in sober living have maintained their recovery, have found a job, have worked with their family, did home visits, and got to be with their kids again. There is the other percentage, that, just their path, I guess, of healing, end up misusing again, having some other things happening or using it and trying to bring that into the center. We can't allow that, of course, because we do have children there. So how do we work with that? But, there's never just a, don't come back and see us when you want the help, basically, how we can work with them. So thank you.
So in one more question, anybody like to ask a question? If not, we'll go ahead and close out the program, and we'll go ahead and transition to our next breakout session. So after this, we have our break, and then, of course, visit the resource fair out there, and we like to extend our appreciation to Indian Health Services, to the Navajo Nation, and to the 638 programs. You all play a vital and important part in the health care of our individuals, whether it's coming from behavioral and mental health, but also our physical health and spirituality. I'm glad that you all were able to touch up on all of those. So thank you very much again, and then I hope you're continuing to enjoy the summit here. So we have a 15-minute break at 2:15. We can reconvene in here. Is going to be opioid settlement funds. In Library 1 is naloxone training and distribution. And then in Library 2 is sacred wisdom, healing from the devastation of American Indian historical trauma. So you all are officially on a break, and start a dialogue out there with the resources. Thank you very much.